Good afternoon, students. Good afternoon, colleagues. My name is Catherine Dihale, and I'm a trainee career guidance practitioner, and I'll be your program director for today. Firstly, I would like to call Ms. Sizakele Msizi, who's also a student mentor at the Counseling and Career Development Unit at the KZN region, and she will be introducing our first speaker for today.
Dr. Hendricks is an HPCSA registered clinical psychologist with 18 years experience in the public health and higher education sector. Shariefa worked at UKZN as a senior student counselor, where she also trained for her master's in clinical psychology. She's currently the manager of Counselling and Career Development Unit in the KZN region at Unisa. She completed a PhD at UKZN in 2018 on clinical supervision and received the Golden Key Award, rating her in the top 15% of PhD graduates. She has published in peer-reviewed journals on clinical supervision, specifically negative and harmful supervision experiences among psychology interns. In addition, she's presented at local and international conferences on clinical supervision. Her passion lies in therapy, training and supervision. She trains psychologists, interns, and registered counselors at the Durban University of Technology and the University of the Free State on clinical supervision. At Unisa KZN region, she has been instrumental in creating awareness and advocating for interventions that prioritize the mental health and well-being of students in higher education. She has developed and facilitated various mental health workshops and has been at the forefront of this mental health campaign. She runs a part-time private practice with a special interest in mental health, such as depression, bipolar mood disorder, anxiety, burnout, personality disorders, complex trauma, unhealthy relationships, and couples therapy. Thank you.
Thank you, Candice. Let me just go to my PowerPoint. Good morning, good afternoon, everyone, and welcome to the fourth day of our mental health campaign entitled My Mental Health Matters. I read in the chat that some of you had not gotten this invite. It's unfortunate that you didn't. It came to our attention on Monday that the invite wasn't sent out to students last week as we had hoped. Nonetheless, you are here today, and we have two exciting topics today, one being mood disorders, and I'm going to be focusing specifically on bipolar mood disorder, the signs, symptoms, and management. And then I'm going to be followed by my colleague, Bianca Friesler, who's going to be speaking about a very important element that has a link to depression, but also to many other mental health disorders, which is suicide awareness and prevention. So without further ado, let me move into introducing you to this topic. So as the program director and Candice, who introduced me, saying that mental health is something that's very near and dear to me. And indeed it is, and I think it needs to be near and dear to everybody, especially because we have come out of so much, and we're still coming out of so much here in KZN, but also in general, as a country with COVID, as globally as well in terms of COVID, the loss that we've all experienced, whether it's people in our families or friends or colleagues. Many of us were isolated during that period. We've also come through a horrendous civil unrest, as well as the floods, which also saw loss of multiple lives and loss of other aspects of our lives, like our jobs and our finances and so forth. And so you can understand why mental health is so near and dear to me. I've done this for the last 20 years, I think. And it's because none of us are immune to mental health. It affects us as a community, collectively as individuals, families, as well as the broader communities that we come from. Whether we ourselves are inflicted by it or know someone who is, I think we can't turn a blind eye to the fact that mental health is here and that it's here to stay. And so with that, many of us sitting in this space right now are either people that are employed, or we are students, or we're doing both, right? And so if you have a mental illness, and if you're somebody that, succumbs to the culture of denialism, you're going to be somebody that's not going to get the help that you need. And the disorder that I'm talking about today, you know, it's such a difficult disorder to actually diagnose. And so it can go undiagnosed for years and years and years. And even clinicians like myself can miss important aspects of this particular presentation because of the way in which it presents. And so mental health, I'm saying, is important to discuss because it impacts us as students, it impacts us as employees, it impacts our relationships with each other, with our spouses, with our colleagues, with our friends. It results in the workspace, it results in increased absenteeism, poor work performance, reduced productivity, and so forth, right? Now, there are several different types of mental health illnesses. I've decided to speak about bipolar mood disorder today because it also encompasses depression, because depression is one of the episodes, so to speak, of bipolar mood disorder, and they all fall under mood disorders. So I thought that it's important for us to be able to understand both these disorders and to be able to delineate between them. You must understand that mental health is a result of multiple complex factors and the interplay between the biological, the psychological, the emotional, the social, the environment, even the spiritual, right? But the thing about mental health is that everybody stays away from it. This culture of denialism that I mentioned earlier on is as a result of the stigma that is attached to mental health. Many people think, well, if I go and see a psychologist, it must mean I'm mad. It must mean I'm crazy. It must mean there's something wrong with me. And I was saying the other day that many people come for counseling for self-development, to understand themselves better, to develop insight better. Sometimes people come to us for marital issues, or they may come to us because they're having burnout or work stress. So it's not just coming to a psychologist because, you know, you think you are mad or there's something wrong with you. People come to us for many reasons, and I'm saying that because this campaign is about destigmatizing mental illness. It's about destigmatizing the profession. It's about destigmatizing me as a clinician, that people don't come to me because they're mad. I see people from all walks of life, right? Bipolar being one of them. You know, so yeah, so the stigma keeps people from one, seeking treatment, and two, from staying on treatment. And you will see later on with bipolar mood disorder, it is a disorder that is so, what's the word? I think for me, it's a disorder that is really a serious one. It's not something that, you know, you'll get over in 6 months. And I think it's important for me to say that from the very beginning. It's not something that you can get over. It's a lifelong illness. And so with that said, I think, let me go into some stats. In South Africa, there was a large-scale study that was done with some 17 universities across South Africa, and there was a total cohort of about 70,000 students. Now, of those 70,000 students, there was about, I think, 11,000, 16.3% of these students that met criteria for a mood disorder. Right, so mood disorder is a big term. Underneath mood disorder, you can have bipolar, you can have major depression, you can have cyclothymia, postpartum depression, and so forth, right? And this was 30 days before they were even assessed. Then about 7,000 of them experienced a generalized anxiety disorder. 14,000 of them reported symptoms of post-traumatic stress disorder. And this highlights the disturbingly high rates of trauma amongst our younger population. We know in university settings that people often encounter trauma through things like rape, for example. There's murders that happen at university. There's a high rate of suicide that happens at university. And this while young people are watching other young people, right? And so you can understand how this trauma happens. There's also a further concern that substance abuse disorder is sitting at 6.6%. And attention deficit hyperactivity disorder was also extremely high at 21%. That's like 14,000 students out of that 70,000 students. So we have to make mental health a key priority, not only because it leads to lower academic performance, but it's also a very serious and it can be very life-threatening, as I mentioned, in terms of suicide. A large number of young people are killing themselves. In this campaign, one of our events that we did was a placard demonstration to destigmatize mental health. or mental illness rather. And then the second thing we did was we put up a wall of honor for people that died by suicide, because I think there's such a misunderstanding about suicide and why people end up killing themselves. So bipolar mood disorder is exactly that. Bi meaning two, right? A split. There's two extremes, and there's two different realities. One reality is where there's an elevation or an elation of mood, and the other one where there's a depression of mood. Now, bipolar mood disorder tends to affect about 1% of the population in South Africa. It tends to begin in adolescence or even early adulthood, and then unfortunately it continues throughout life. Right, it was further, but before this, it was known as manic depression. You might be familiar with that term. We also find research shows us that bipolar mood disorder can also happen in children, but with children, obviously the behaviors is a little bit different. They tend to mimic symptoms of ADHD. Bipolar mood disorder is also the 6th leading cause of disability in the world. It affects anyone. It doesn't matter your social class, your race, your color, whatever the case may be, your nationality or ethnicity. It can affect anyone. It's more common in females than males, especially bipolar mood disorder 2. It is also regarded as a physical illness, and it is marked. It's by extreme changes in people's moods, especially the energy levels, and that's what distinguishes it from your normal, major depression. The person's thinking and as well as behavior is also altered. It's a debilitating mental illness in that it affects a person's ability to develop relationships and maintain relationships with others. It affects if you're at school, it affects your behavior, your thinking, and so forth when you're at school. Family life, partners who have spouses or people who have spouses with bipolar mood disorder will report that it's very difficult to manage them. And I'll tell you as I go into the symptoms just now why. It also affects people's social life, right? As well as obviously your occupational or work functioning. So it falls under mood disorders, and a mood disorder is, as I mentioned, a mental health problem. And this obviously, as the word entails, it's tied to changes in your mood. Right? And changes in mood obviously lead to changes in behavior. So both major depression and bipolar mood disorder fall under mood disorders, and it's the most common types of mood disorders. There are others, like I mentioned, cyclothymia, which is also part of the family of bipolar mood disorder. Then we have disruptive mood dysregulation disorder, then dysthymia, and dysthymia is now no longer called dysthymia, it's now called persistent depressive disorder. It's a little bit of a milder version of depression where the person is just low every day, but it's not as dangerous as like your major depression or your bipolar or cyclothymia. There's also premenstrual dysphoric disorder. And this is usually quite a serious disorder. It's now diagnosable, by the way, for women who experience severe PMS. Seasonal affective disorder, which, as the name also entails, happens during certain seasons, usually in the winter months. Then we have depression caused by a medical illness or a neurological disorder or by some kind of substance or medication. So medical illnesses will be like, for example, some people who have a stroke may develop depression as an add-on following the stroke because of the loss of the ability to speak, the ability to walk, and so forth. There's also, for example, other terminal illnesses like cancer, where people may develop a mental illness like depression as a result of the diagnosis. We have postpartum disorder that also falls under this, and postpartum, as it entails, is related to women who give birth. You might know this as the baby blues. And then, of course, the psychotic depression. I'm going to focus specifically on bipolar mood disorder. And I think because I've always focused on depression, I thought this was an interesting topic. Many people with bipolar mood disorder fall under the radar and don't get diagnosed for years and years because sometimes the symptoms are so isolated. So, as I said, it's a lifelong disorder. It causes severe shifts in mood and energy levels. So you would know that with depression, for example, someone who just has a depression will have no energy or low energy. Someone with a bipolar mood disorder will have high energy, right? Their thinking patterns become distorted as well as their behavior. Now, cyclothymia is under the family of bipolar, under the family of mood disorders, rather. It falls within the ambit of bipolar disorders as well. But the difference here is that with cyclothymia, it's more longer in terms of its duration. There's aggression that you'll find with people with cyclothymia. There's irritability as well as inattentiveness that is far more prominent than, for example, bipolar 1 and bipolar 2. With bipolar, you will find that the reason why it makes it difficult for you to study as a student maybe, or to work in a job that requires your full attention, is because concentration, alertness, motivation, and so forth becomes a problem, right? Even processing speed may occur throughout the whole school week for a child. The symptoms usually affect people's behavior as well as their academic performance. People with bipolar mood disorder find it very difficult to concentrate, so they can't study. Sometimes they can't complete their degrees because they experience certain symptoms, which I will go into when I speak about the different phases. I'm just giving you general facts about the disorder. So hypomania and mania are two aspects of bipolar 1 disorder. And these two particular episodes is what makes it different from your ordinary depression, right? And which makes it difficult for you to stay focused and complete a task. It cycles with the depressive episodes, which are also far more disabling than when somebody has just a normal depression. So that makes it very hard for someone to focus, to remain motivated, to concentrate on what they need to do. People with bipolar disorder will also not be able to complete higher education because often it requires frequent hospitalizations. It requires you to stay on medication. And because of non-compliance, lots of people end up having to go into hospital because they slip into a manic episode. As I said, it is common in children. It often is misdiagnosed as ADHD. And children who do have this, you'll find that their memory is problematic, or they're easily forgetful, or they can't recall things. And so educational attainment and memory deficits may also then affect learning in turn. So besides being rich and famous, what do you think these particular celebrities have in common? We have The Rock there, Demi Lovato, Britney Spears, and our own Trevor Noah. They all have bipolar mood disorder, right? They're all working, which gives us some hope. So that's quite interesting that, and that's only 4 celebrities, by the way. There are so many others: Catherine Zeta-Jones, Lady Gaga, Selena Gomez, so many of them that have bipolar disorder and are functioning. But they're functioning because they are people that are willing to seek the help. There are people that are willing to go on to medication. There are people that are willing to stay on the medication, right? So let's just go into the classification and the types of bipolar mood disorder. As I said, it falls under mood disorders. There are 3 types of bipolar disorder: bipolar 1, bipolar 2, and cyclothymic disorders. Bipolar 1 disorder, you'll find somebody who is diagnosed with this would have had to experience one major depressive episode. So a major depressive episode will have all the symptoms of depression. Then they will have to have had at least one episode of mania, meeting all the symptoms of mania, and I'm going to take you through that just now. Then at least one mixed episode, right? Meaning they must have had a mixed episode where there was depression and mania together, or depression, mania, and hypomania. People with bipolar 2 disorder, which is the prognosis is a little bit different for bipolar 2 disorder, they will have experienced a major depressive episode. The problem with bipolar 2 disorder is that the major depressive part of this illness is really it's very severe. Whereas in bipolar 1, the mania is the severe one. And then the other difference with bipolar 2 is that there's no mania, but there is hypomania. And I think that's what makes it different for people with bipolar 2 to actually cope and actually work, because hypomania is not as bad as the mania. It's like mania, but it's a less severe form, right? Then we have the third one, which is cyclothymic disorders. Here, the person would have experienced a number of hypomanic episodes and a number of depressed episodes, right? And when they are depressed, they would have experienced several periods of having loss of interest or pleasure that do not meet the criteria for depressive episode. They would have had a 1 year duration of if they were adolescent, and 2 years if they were an adult. So, for example, if you were 16 years old and you had a hypomanic episode, right? You can't just have one hypomanic episode to qualify as somebody who has cyclothymia. You must have had 3 or 4, 2, 3, 4, 5, 6. And that must have been present for at least a year. If you were an adult, same, but only it must be present for 2 years in order for you to be classified or diagnosed with cyclothymia. And then the third thing is that the symptoms can't be severe enough to meet the diagnostic criteria for either bipolar 1 or bipolar 2, and there must be no major depressive episodes. So you can see here that it's a normal depressed episode, no major depressive episodes. As I said to you, bipolar 2 is where the major depressive episode is. So this is very confusing, as you can see. It's even confusing for psychologists who are trying to understand what the patient is presenting, what the client is saying, in terms of how they are experiencing their thought process, their behavior, their mood. And it's difficult for us to track. And hence you'll find that's why the compliance rate with medication for people with bipolar disorder is so poor, because the doctors tend to, how can I put it, go via trial and error, trying to find the best fit with the best kind of medication so that they can alleviate either a mania or a depressive or a hypomanic episode. So let's delve a little bit more deeper into this. So like I said, so there are 4 episodes that make up bipolar disorder, right? There's the depression, the mania, the hypomania, and then a combination of these, which is a mixed episode, right? So your depression would be the same as any other depressive episode. The major depression is a little bit different. So just an overview here. I said that it was extreme highs and lows. It means that there's an extreme shift in mood, right? So people who have bipolar mood disorder, if they are in the manic phase, they feel like they're on the top of the world, right? They will talk fast. They will drive fast. They will spend money that they don't have. They will be extremely high. They will laugh. They will even dress loud, in loud colors, right? Now, that mania doesn't last very long. So sometimes it's actually quick to pick up because the person is speaking fast. There's like a pressure of speech, so to speak. Right? So they're on the top of the world. They're invincible. Right? They may even experience what we call micropsychotic episodes in that time where they feel that they have certain magical powers, right? So the manic episode, as I said, lasts for about 4 to 5 days, at most 1 week. But the problem with mania is that, unlike depression, sometimes mania requires the person to be hospitalized. You can experience depression and not be hospitalized. If you have major depression, yes, then you're going to have to be hospitalized because then you're suicidal, right? The manic episodes are bad because of the elevated mood, the increased energy, and the person is also very impulsive, meaning that they will go out and max out their credit card, for example, meaning that they will experience hallucinations and delusions in that time while they're manic. It doesn't last for a long time. It only lasts, I can't think that it would last for long, because imagine going 4, 5, 6 days with no sleep, right? This person will not sleep for days on end. The person will be up, walking up and down in the house, leaving the house, running in the street. Some people even, take off their clothes. They start hearing voices. They will go into they'll go and find parties, for example, just so that they can, abuse drugs, abuse alcohol. Some of them go on these sex sprees where they sleep around with a whole lot of people. Right. And that's how erratic, that's how expansive the behavior can actually get during a manic episode. With the depressive part of this illness, there is more sadness, there's a low energy, and you can see the person, the moment they've done with those 4 days of mania, they come crashing down into this low energy, the sadness, the suicidal behavior where they can't, don't want to eat, and they're hopeless and helpless and so forth. Many people with bipolar disorder become very suicidal and are actually 20 times more likely to commit suicide. And I think this is where the danger and the life-threatening aspect comes in to the illness, right? I've mentioned the micropsychotic. The thing is just to look out for, if you know somebody, who has bipolar, look out for some of the warning signs. They might give their things away. They stop putting their affairs in order and so forth. They might also, do very risky, get involved in very risky behaviors. So let's look specifically now at these criteria. The mood needs to be abnormal and persistent, right? And that mood needs to be either elevated, expansive, or irritable, and it must last for at least 1 week, right? And in this time of this mood disturbance, this person will have an inflated sense of self. So they'll act grandiose. You'll even get people who will say, I'm Jesus Christ, or I'm some kind of prophet, or I can read your thoughts, that kind of thing, right? They become very, very talkative. They don't give you a chance to speak. They speak on end. There's no full stops in between, or they talk incessantly. And you'll know this because it's different from how they normally are. They may have a flight of ideas, or even a subjective experience that their thoughts are racing. And they may even say, my thoughts are going out of my head, or there are thoughts coming into my head. Or there's so many ideas that are flowing around in my head. Now, remember, don't look at one symptom and say, oh, well, this person's manic. You're looking for at least 3 of these symptoms, right? There's also increased distractibility. So there's, just to any kind of external thing that's happening outside of themselves, they become distracted by that. Their goal-directed activities increased. And then there's this excessive involvement in pleasurable activities. And the thing is that every one of us likes a good party, but people who are experiencing this expansive mood look for parties or look for events or experiences that have painful consequences for them, right? And so, so as I said, there's this pressure of speech, there's reckless behavior. So the mania part of this illness is the one that is, for me, I think, difficult to manage, because sometimes the medication that they're on may put them in a manic phase. And you can think about this. If you're bipolar and you get placed on medication, you can be placed on an antidepressant, right? The antidepressant is to help you to stop feeling sad. But if you get too much of a dosage into your system, it's going to start sending you into mania, isn't it? Then you've got to up the mania medication, which then sends you into a depression. So this is the dilemma. This is the problem that many psychiatrists tend to, have a difficult time with, especially early in the diagnosis of the person, where they try and find a dosage that is compatible with the person's presentation, so that it doesn't send them, because it has to be constantly monitored and constantly changed, so that it doesn't send them prematurely into either a depressive or manic phase. All right, so so let me move on from this. So I thought, let me just explain to you what is an expansive mood. So people who are expansive will express their emotion in a very intense way. If they talk about themselves, it's this exaggerated sense of self-importance. They'll become excessively friendly, or even if it's a romantic partner, they'll be excessively romantic, more than they usually are, right? They may act larger than life, more grandiose, more superior than everybody else. And if you know the person well, you'll know something is off, something is not right with this person, right? Like, for example, if they come and see me in my practice, the way in which they speak about themselves as a husband or as a father or as an employee or as a friend, and how good they are at A, B, and C, and what a great friend they are, and what a great husband they are, and what kinds of things they do for their family. You kind of start picking up a pattern that there's something going on here, and then you start looking for other clues, right, of this kind of exaggerated, expansive mood. Hypomania, as I said, is a lesser form of mania. Also here, there's elevated and expansive or irritable mood, but it lasts for 4 days as well. And it's different from the usual non-depressed mood the person might experience, right? Same here. It's the same symptoms as mania. It's just at a different level. The person, however, with mania will not have, for example, I think the distinctive feature here, they won't have psychotic symptoms. Whereas with mania, there's a psychosis there, you know, the delusions and hallucinations I mentioned. But everything else stays the same. They don't want to sleep, or they have a decreased need for sleep. They're far more talkative than usual. They also have the same flight of ideas. They also have that increase in goal-directed activity. They want to do what they want to do. They also get involved in pleasurable activities with painful consequences. But the distinction here, as I said, no psychotic features, and people with hypomania or bipolar 2 are able to work. They can function. They don't have meltdowns. They don't have psychotic breaks. None of that kind of stuff, right? And of course, everybody knows the symptoms of depression, which is the other episodes that can happen with bipolar 1 disorder. So here it's sad and persistent mood, loss of interest in pleasure. So remember, with mania, there's an increase in pleasurable activities with painful consequences. People who are depressed often are helpless and hopeless and worthless. They may have insomnia. They may have low energy. They may have no motivation. Cognitively, they may have poor concentration, forgetfulness, and memory loss. They may also have low libido, whereas with mania, there's an increase in the libido. But also the other thing is that people who have depression will then also have thoughts of suicide. Now, I want us to understand something with bipolar. Remember, bipolar involves episodes of depression, episodes of mania. They can co-occur. Some people can have this happen in the day where you can feel depressed in the morning and then very elevated in the evening, right? The thing is that they can also occur on its own. So depression can happen for months on end, and then something can trigger you, and then you can go into a mania. And then you can slip back into a depression, and then you can go into a hypomania. Then you would be classified as having at least one of each of those episodes, and then you will be diagnosed with bipolar 1 disorder. If you experience depression, or at least a major depression, as well as a hypomania, and I've taken you through the hypomania slide just now, then you will be diagnosed with bipolar. You have to have at least one each of those. Bipolar 2, sorry. One each of hypomania and depression. You will have bipolar mood disorder diagnosis. If you had several hypomanic episodes and several depressive episodes, you will then be diagnosed with cyclothymia. I hope that is clear before I move on, right? So here's this mixed episode I spoke about earlier on, right? When depression and mania happen at the same time. This also can result in a lot of unpredictable behavior. A person can take a lot of dangerous risks. They can become very, very suicidal, agitated, and energized. It's very common in women and people that have had a diagnosis of bipolar mood disorder at a very young age. So if you were like 12, 13, or even younger than that, where you've had a diagnosis of bipolar disorder, then you're more likely than others to have a mixed episode. Let's move on. Then we have what we call rapid cycling, okay? So keep in mind those 4 episodes I spoke about just now. If you have experienced, let's say, 4 or more depressive, manic, or hypomanic episodes, or even mixed episodes in 1 year, your psychiatrist will say that you have bipolar 1 or 2 with rapid cycling, meaning that you have many episodes. Some people can go for a long time. I recall once I was working at Addington Hospital, and I had a patient that I was asked to see for grief. And this patient apparently had had bipolar mood disorder 2 for many, many years. But then her father died. And that's why she was in the hospital, because she experienced hypomania, and she was hospitalized to manage that. But she had been fully functioning, had a business, she was a businesswoman, and when her father died, that triggered a hypomanic episode, and that needed to be, managed in a hospital setting. And that's the thing about bipolar mood disorder. Often it requires inpatient care. It can be managed with outpatient care. It can be managed privately or through a government hospital. But a lot of the time when a person has either, mania or a severe depressive episode that, has suicide attached to it as a possible manifestation, then the person has to be hospitalized, because then they can't keep themselves safe. And you can't guarantee their safety either. So rapid cycling means that you would have experienced episodes of mania or even hypermania, then followed by episodes of depression. You may feel stable for many, many weeks, between your episodes, but then you may cycle between your mania and other stable periods. These periods can last days, weeks, or months. I've seen somebody rapid cycle within a day. Some people rapid cycle within a week. So in 1 week, they may have mania and depression, right? So remember, there's 7 days in a week. You need 4 days for mania, then you come crashing down into a depressive episode, and then you can become very suicidal. So on Sunday, you could have been very happy and, partying, and then the following Sunday, you're wanting to kill yourself. So the prognosis for this disorder is really poor, and it pains me to say that. And, the micropsychotic episodes make it, really bad for somebody with bipolar 1 because, there's hallucinations, there's delusions. And when there's rapid speech or there's, flight of ideas or any kind of distorted thought process, it makes it very difficult for the person. The person may hear voices, may even have command hallucinations. It says, don't take your medication. So then the person will be defaulting on their medication. So it's not a disease, it's not an illness. I don't want to call it a disease. It's not an illness to be played around with or be taken lightly. I think it must be taken seriously. It's an illness that would, like I said, is lifelong and requires medication. And requires you to be staying on that medication for a very, very long time. So this brings me to the causes of bipolar mood disorder. Often, if there is a family history, this is a single best predictor. In 20% of the cases, this is genetically linked. If somebody has depression, usually on the paternal side, you do have a high risk of inheriting this illness. There's a stressful life event. We all know about the diathesis stress model. If you don't, it means that stress can actually trigger you to get a bipolar episode. It can make your symptoms feel a lot more intense or even difficult to manage. Some people who have like a very intense breakup in a relationship or has been in a relationship that's abusive or where there's trauma that was involved may also, experience this. If you've had like tragic or traumatic loss, this can also trigger off an episode. Children who've had subjected to childhood trauma later on in their life are triggered by other traumatic stressful life events, can develop bipolar mood disorder because it can affect you in terms of, your other emotions that you have to manage, like the neglect, the abuse, the loss, especially through death. I mean, I know people who have, as a result of being raped, who were fine, and then all of a sudden, because of the trauma of the rape, the depression obviously came first, and afterwards there was a bipolar mood disorder that happened as a result. There was another woman I knew who was a victim of domestic violence, and we diagnosed her with bipolar. It appears as though there wasn't a cause effect there because she had been experiencing partner relational difficulties because of the mania part of her illness, which was not diagnosed at the time. And it was causing problems with her husband because she would go missing for days on end and her husband wouldn't know where she was. And so when there's impairment in emotion identification and when there's hypersensitive perception of fear and anger, it may also trigger off a bipolar mood episode. How does it impact your daily life when it's not under control? It can cause a lot of problems for people, especially in your work or your job, in your relationships, especially if a partner doesn't understand. If you're in manic and you leave your partner and go away and you disappear, for days on end and your partner doesn't know where you are. It can also impact your sleep because, as I said, when you're manic, you have a reduced need for sleep. You can go 3-4 days without sleeping. It can affect your health because you will start drinking and abusing drugs. It can also affect money because you will max out credit cards. You will make big purchases while you're manic without realizing that you are. It can also lead to lots of risky behaviors, meaning several sexual partners and placing yourself in a position where you become at risk by other people. It can also be very stressful for those who love you, to care about you, because they don't know how to help you. They don't understand what's going on with you. So it's important that you get the help that you need. In terms of employment, There's lots of implications for employment. There's high absenteeism. I think 19% absenteeism for people who have bipolar mood disorder. There's slow productivity. Relationships with colleagues can easily become strained because of the irritable mood and your sense of superiority in the workspace, where you will give no one else a chance to speak, and you will obviously bombard other people with ideas. They don't know that you're bipolar. And so forth. You may also face discrimination in the workplace, and hence you may not disclose that you have bipolar. It will interfere with your work because of the memory issues, all of the cognitive dysfunction that happens when you're manic. Even when you're depressed, there's cognitive dysfunction in terms of memory, forgetfulness, concentration, and so forth, right? Your mood is one of the biggest things, I think, that affects relationships and interpersonally, especially with whether it's partners, colleagues, or friends. That's one of the biggest implications. One of the ways to cope with this is, try to stick to a routine, try to take scheduled breaks, often go out, take a walk outside of your office, especially in lunchtime. Try to practice deep breathing at your desk. Try to meditate a lot. Find a support system at work, even at home or even outside of home and work. Take time off from work when you need to. Right, so let's look at the management. The first line management for bipolar, of course, is pharmacotherapy. And this entails having to be placed on a combination of medication. Now, if you have depression, for example, you might be on something for sleep, and you might be on something for the depression. When you have bipolar, whether it's bipolar 1, bipolar 2, or cyclothymia, you would have to go on an antipsychotic because of the psychotic symptoms that happen during mania. You will have to go on a mood stabilizer because of the intense rage and the shifts in your mood. And this entails things like lithium and valproate and carbamazepine, right? And you'll have to go on an antidepressant as well. The problem with this, okay, so one of the things the psychiatrists do, from what I know, is that they start low and they go slow. So usually when people are first diagnosed, it's very sketchy. It's not very clear whether they have bipolar at all. So they start treating a depression first, and then they start watching for symptoms of mania, if those were reported by the person who brought you in, or by yourself. If you've already been diagnosed and you've defaulted and you come in, of course, they're going to put you on all of these medications to try and help you to manage them. As I was mentioned early in the presentation, from what I've seen, some of the patients or clients with bipolar, when they are depressed, right, they are taking an antidepressant and whatever dosage that might be, and they're fine on that dosage. And then something may happen, or maybe nothing even happens. But as their system gets used to the antidepressant, the mania starts creeping in and they have a full-blown manic episode. And then when they come in, obviously they come in because now they're suicidal because they crashed after those 4 days. The doctors then put them on medication to help balance that. And I was finding that people were moving, like shifting, so much between the depression and mania. Every single month, you would find a patient coming back and say, no, I was manic or I was hypomanic. And so it was really sad to see that. But it was also encouraging that they kept up with their therapies, they were compliant on their medication, and some stability was seen over time. And this is the thing. You have to be in it for the long haul when you're trying to manage bipolar, right? Psychotherapy works wonders because it helps in terms of psychoeducating your family, educating you as well about the disorder itself, how to self-manage. Joining a support group, there's a number of support groups. Even SADAG has several bipolar mood disorder support groups that you can get a hold of and you can join to understand the illness better, to understand yourself better. There are also supports for parents with children who have bipolar. And the use of empathic validation, understanding that this illness is not something you brought on yourself. It's not self-inflicted. Validating that, listen, I have this illness. These are the things, I am not my illness. I go through these episodes. These are the things that I experience. Because the moment you start putting yourself down around your illness, It's when you start stigmatizing this illness. It's when you start saying, I give up. It's when you're saying, I'm hopeless, I'm helpless, I'm not prepared to do anything about this illness, right? So empathic validation is important, understanding what you are going through, or even understanding what someone else is going through, and then validating that experience without stigmatizing them. So in terms of the psychotherapies that we offer for bipolar disorder, cognitive behavior therapy obviously comes up as one of the most eloquent and I think trusted therapies, because here, we're focusing on thoughts and feelings. Remember, when you have bipolar, it's not just about changing your thoughts about the illness. We're not changing the symptoms. We're changing how you think about your illness, how you think about managing your illness. All the fears about, I deserve this, I'm a failure, that's why I've got bipolar mood disorder. All those things interfere with how you manage. So hence we would do cognitive behavior therapy so that we can help you change your thought patterns, and which in turn obviously would then change how you feel and how you behave. There's also interpersonal therapy, and this focuses on your relationships with people. Often your therapist would do, a combination of therapies, not just focus on CBT. So it looks at how your relationships affects how you feel about yourself, how you think about yourself, and how those in turn affects your relationships. There's also behavioral couples therapy for couples who are going through bipolar, one partner has bipolar. And here the focus really is looking at some of the problems, the emotional difficulties that the disease causes for the person and for the relationship, and how they can resolve that between themselves as partners, and how the partner can be of more support. Individual psychoeducation, I think, is self-explanatory. It's just identifying, what are my triggers? What are my first symptoms that come along? What are some of the warning signs, and how to develop coping strategies around there? So when you know what the illness is, when you've got a proper diagnosis, 2, you understand whether you're a rapid cycler or not, exactly, these symptoms lead to depression, or these symptoms I know will lead to mania, then you know what to do. So especially, for example, people who can predict, I'm going into a manic phase. You can tell loved ones around you, listen, I don't feel well. I'm sensing, I can't sleep very much these days. I'm sensing that I'm heading towards a manic episode. Just keep an eye out on me. Can I stay with you for a few days so that I don't get out and go and do all these things and spend money that I don't have, or sleep around with people that I shouldn't be sleeping around with. Group psychoeducation, again, this is in a group format that happens, where people with shared experiences come together, especially people who are bipolar, who've been through things, who can help you, through identification with other people. You realize, okay, I'm not alone with my problems. There's other people who've gotten through worse than me. So this helps you to build self-management skills. And usually, like at SADAG, there are people that are trained to help you through this process. Places like Akiso and St. Joseph's and so forth here in Durban have groups, with OTs and psychologists who run groups every day to help people to cope and manage better when they're outside of places like Akiso and other institutions. When we focus on family, when we do family focus therapy, here obviously we're helping the family to identify some of the behavioral traits, how they can identify risks, how they can build better communication with the person, how they can build better coping and better problem solving. Remember that both, whether it's depression or whether it's one of the bipolar disorders, both the first line pharmacotherapy and psychotherapy have to go hand in hand. You can't do one without the other, because often, like I said, if the cause is trauma, the person has to understand that my trauma is one of the things that have triggered me to get in this bipolar, and I need to work through my trauma so that I can alleviate, or I can lessen some of the symptoms that I have. So talk therapy is a given. You have to go to therapy to be able to process what's going on. It will not resolve the rape, for example, but it will help you process and understand. It will help you move away from the guilt and the self-blame, right? And whatever else you might be going through. So like I'm saying here, that in the long term, when you do talk therapy, it helps you to understand, make sense, and process and find meaning in your illness. Because often people will say, yeah, I deserve to get this bipolar. Everything else has happened to me, so I deserve this too. And that, obviously, you can see how CBT can come in there and help you to change that thought pattern. It can also help you to reflect on the impact that bipolar has had on you throughout your life. It can help you to develop some self-empathy and self-compassion. It'll help you to also identify some of your own warning signs and your own symptoms. help you to develop strategies to cope better, especially with other triggers and with certain episodes, like with your mania. It'll help you to develop a crisis plan, as well as set goals and plans for staying well. Right, I've mentioned these medications before. Valproate, I think one of the things I wanted to mention about valproate is that if you're pregnant, it has serious side effects for people that are pregnant. Remember that medication will be lifelong. Sometimes people don't want to take the medication because they think, well, I take medication, it has all of these side effects, and people are going to think I'm crazy. And when they don't take the medication, obviously defaulting makes you relapse. When you relapse, your episodes will be more intense. And yeah, it's actually more difficult when you're not on medication. It's one of those disorders like schizophrenia, for example. You have to go on a medication with schizophrenia to help you manage the psychotic symptoms. So bipolar disorder is the same, right? Some of the self-care strategies: try to get to know your moods, what your triggers and warning signs are. Monitor them. Use a mood diary, whether it's like something like Mood Panda or eMood. Try to use a mood diary. Write it down. Feeling irritable, feeling agitated, feeling high, feeling low, whatever the mood may be. Understand your own triggers. Each of us have individual triggers. We have people that trigger us, situations that triggers us. So find what yours are. You might even see like certain people or certain behaviors or a situation might trigger you into a manic or hypomanic episode. You might also find that after a late night, your mood is changing. When you understand these patterns, and you can try to avoid the triggers, and you can also then minimize the impact. Know what your warning signs are. You may notice there are certain patterns that help you to feel a particular way, or helps you to identify. For example, I know I had a client once who is sitting late at night at television, and she would watch this dramatic, I think CSI it was called, or something, or NYPD or something. She would watch this, and she would become extremely affected by this external stimuli. And then the next day, she would automatically get triggered into this manic episode because it would trigger her own trauma. So be careful of what triggers you. I mean, something as simple as listening to a song could trigger you. So notice when there's a pattern to how you feel or behave just before an episode. I think that for me, when I had a bipolar group, was one of the things I think they found most useful, is being able to keep that mood journal and keeping a journal of what triggers them. Because I think this is the one thing that helps you feel more safe and more in control of your illness, right? Learn your own warning signs, plan ahead for a crisis. When you're having a mental health crisis, it can be very difficult to let other people know, especially because there's specific help that you might need, and they may not know what help you need. So disclosing to a trusted friend or a trusted colleague is helpful. You can also write down your own crisis plan, that when I become this way, please do this. Please make sure that I'm taking my medication. Please take away all my gadgets. Make sure that I'm sleeping, and so forth, right? Because when you do these things, you might think, but Shariefa, I already have bipolar. What's the point? When you put these things in place, you lessen the intensity of the episode. You lessen the frequency and the duration of the episode as well, right? I thought it was important to just kind of highlight maybe some of the best and worst jobs for people with bipolar, because often people with bipolar 1 can't really sustain and hold on a job because of the mania, especially if they go into mania quite a bit, because it makes it difficult for them. So find a job that has consistent hours. So stay away from jobs that have shifts, night shift, where it affects your circadian rhythm and your sleep pattern. Part-time and remote work is actually better because it offers you that flexibility. They say that bipolar people are very, very creative, right? And so they will obviously thrive in jobs where they are creatively stimulated. So find jobs that have this, where there's low stress, there's a relaxed environment, and you have an opportunity for a creative outlook. For example, writing, or being a writer or journalist, being a hairstylist, a makeup artist, and so forth. If you're looking for a more calmer environment, then you'll be somebody that would enjoy being in a library setting, being a tutor, maybe being a yoga teacher or massage therapist. Even part-time work is good, so you don't work full-time, so you can still work. but you limit the number of days that you work so there's not a lot of pressure on you, and you have days in between where you can recover and recoup. So things like being a proofreader, being an accountant, or even a receptionist. The worst jobs that you could do, is jobs, for example, working as a bouncer in a nightclub. Working where in a call center, for example, where you're having to work late hours and long hours, right? You must understand your boundaries and your triggers, especially when it comes to choosing a job. Understand your work environment. If your work environment is draining, if it's overstimulating, if it's overwhelming, if there's toxicity, if it's inconsistent, these can not only trigger, but it can also aggravate symptoms for you. And so it will not be suitable for someone like yourself. People that are emergency rescue workers and so forth, firefighters and so forth, teachers, wara, all of those shifts, waiters, all those that involve night kind of work, long hours on your feet, dealing with a whole lot of people, often are not good jobs to get into. Medicine, for example, nursing, all those kinds of jobs are not good jobs for you to get into. How can you help yourself? I've said this more than once today. Take your meds, don't default. Try to remember that you must eat the 3 meals a day, even when you don't feel like it. Stay away from stimulating activities, stay away from noisy, bright, environments like gambling spaces like your Sibayas and so forth. Surround yourself with people that are calm. Surround yourself with an environment that is calm and relaxing. Try and find activities that soothe you. Remember, when you are manic, you're highly elevated, meaning that you are someone that's on steroids. So you're wanting to do things like yoga, meditation. You're wanting to be in a calm frame of mind. So find things and activities, people, environments that bring that on. Think about your finances, know your triggers. When you know those early warning signs, give your credit cards to family members who you trust and say, keep this away from me because I don't want to go on a spending spree. Don't make any major life decisions. Avoid any situation where you're going to get involved in any kind of risky behavior. For example, if somebody's inviting you to a party and for days you've been feeling this mania come on, stay away, say no. Stay away from recreational drugs, stay away from social drinking. Limit alcohol. Please limit alcohol because alcohol tends to trigger and exacerbate mania. Learn how to have good boundaries. Say no to people that are demanding things from you. Make use of people that are, your peers that want to support you. Don't be afraid to make use of that, right? In terms of your sleep routine, go to bed early. Even when you're not tired, go and lie in bed, right? Get into a regular sleep routine. Same time every day, go to sleep. Same time you must wake up every day. Don't nap in between because then that makes you not want to sleep. And especially if you're going into a mania, remember you have a reduced need to sleep. So if you're sleeping during the day, that is going to be more intense and it's going to last longer. Don't stay in bed awake for more than 5 to 10 minutes. Try to get up. Even if it means at 5 o'clock in the morning, you've got to move to a chair that's dark. Don't go on your phone just before falling asleep. Don't watch TV before you fall asleep. Avoid any kind of substance, alcohol before you go into sleep, because this might affect your sleep patterns. Some people are triggered even by caffeine, by cigarettes and so forth, and even over-the-counter medication. Read the side effects of over-the-counter medication to see how they will impact you if you have bipolar. Exercise, every mental illness will tell you, any therapist who's managing a mental illness will tell you to exercise every single day. But with bipolar, try to do it early. Don't do it late at night or after 5. Have a quiet, comfortable bedroom. Surround yourself with a bedroom that's conducive, that's calming, relaxing, and quiet. Move if it's cluttered, move the clutter out of your bedroom so that because remember, your mind becomes cluttered through what you see and what you envision. Put your watch away if you're somebody that watches your watch all the time to see, because that can also become quite triggering. And just have a comfortable pre-bedtime routine. If you're wanting to support someone with bipolar, just try and be a friend, be kind, be empathic, validate what they're going through, understand, even if you don't understand, let your face communicate that you understand that this is difficult for them. It's not easy. Don't make them feel worse than they're already feeling. They have no control over this. it's something that's happening in their brain, and only medication can help in that moment. So try and be the friend that is kind, listen to what they have to say, ask lots of questions if you don't understand. Nothing is too silly. Ask them what helps them, ask them what help that they want and need. Try to be positive, try to be supportive, let them know that you're there and that they're not alone. If you notice changes in the behavior, bring it to the attention. Say to them, I'm worried about you. I see this happening. Are you okay? Do you need anything? Try not to be judgmental when you do so. Try to advocate on behalf of a co-worker. If you know a co-worker can't speak up, try to advocate on their behalf. Try to be with them during a manic phase. If you don't know anything about bipolar, try to educate yourself about mania, about depression, about rapid cycling and so forth, so that you understand where the person is at. I can't emphasize more than I've already emphasized in this entire presentation, that if you fail to seek for help, it's going to have dire consequences, even life-threatening consequences, because whether you're in manic or in a depressive phase, either one can be life-threatening. When you don't seek help early on, especially with your trauma, try to seek help. If you haven't got bipolar yet, but you have a trauma, I'm not saying you're going to get bipolar, but I'm saying go and look for help for your trauma, try to process your trauma. Make sure also that if you are somebody that is reluctant to speak, maybe start speaking to a friend first before you start speaking to a therapist. That might be less threatening, I suppose. Remember that if you don't seek help timelessly, it can also lead you to develop like anxiety. It may also make you start abusing substances just so that you can cope. It can also result in unfortunately, in increased thoughts of suicide and even suicide attempts. So stay on your medication. If you're not on medication and you suspect you might have bipolar, try and get yourself diagnosed. Get yourself into some form of therapy. Stick to the therapy. Start with the self-managing behaviors, and try and do what you can for yourself. And that brings us to the end, and I'd like to thank you.
Thank you so much, Dr. Hendricks, for your insightful presentation. I don't know if you'd like to take some questions now, or if I should call on Rolene first.
I don't mind taking if there are any questions.
Okay, Candace, do we have anything on the chat?
Yes, we have quite a few questions. Let me just check the chat. Someone asked, is there a way to test? Is there a test I could take to know if I'm suffering from bipolar, or if it's just stress or depression? How do you notice how do you know you have bipolar? I think some of that, Dr. Hendricks, you would have responded to, but is there a test one takes?
I think there is a bipolar scale, which you obviously would have to go via there are probably online stuff, but you go via a psychologist who can obviously assess you and do a clinical interview to understand. Because I think people also mustn't be too quick to think that they have bipolar, because especially with the mania, people think, oh, if I'm very happy-go-lucky, it might mean that I'm manic. No, you're not manic. Like I said, mania is distinct. The mood is so big. The mood is so loud. You're like this person that's on top of the world. It's like impossible for people to handle or manage you. You're like too much for the person. You're too loud. You talk too much. You're all over the place. You're like somebody that's on steroids. Like, have you seen a child that's ADHD? Now multiply that by 10 times for somebody in mania. And this is an adult we're talking about. So, yeah, I mean, I think get yourself you are professionally assessed before self-diagnosing, because whatever you're experiencing might be related to something else, or not necessarily bipolar mood disorder. With mania, remember I said there has to be, to meet the criteria for mania, and obviously then for bipolar would be that you would have to have micropsychotic episodes. and you would have had to have all those other things I mentioned. Decreased need for sleep, the excessive talkativeness, the hallucinations, the delusions, the flight of ideas, all of that you would have had to experience.
Thank you. The next question posed by Julian is, how closely related is bipolar mood disorder 1 or 2 and ADHD?
ADHD.
Yes. Is the different?
It's different. No, the presentation is totally different. So I mentioned, if you were here in the beginning, I told you the difference between bipolar 1 and bipolar 2. So bipolar 1 obviously has depression, mania, and a mixed episodes, whereas bipolar 2 has hypomania and depression. And ADHD obviously is different. It's totally different. There's no psychotic symptoms in ADHD. You know, there's the poor concentration, the restlessness, the impulsivity. So impulsivity is also the same in bipolar. ADHD, obviously, it's aligned with other symptoms. With ADHD, for example, it's like the person is running on a motor, for example, with children. You'll see that. The poor concentration, the inattention, the hyperactivity, and then there's the impulsivity. I think our speaker yesterday spoke about ADD and then ADHD. And so impulsivity, you know, forms part of that kind of presentation of the ADHD, not necessarily being a link with ADHD. I do know that with children, often there's this not a dual diagnosis, but almost an overlap of symptoms between ADHD and bipolar. And there have been many children that have been diagnosed with bipolar mood disorder who were initially diagnosed with ADHD, but bipolar is a more severe form. ADHD is still milder, you know. Like I said, with cyclothymic, for example, there's an inattention, but there's also a violence and aggression with cyclothymic that you don't see with bipolar 1 and 2. Similarly, with ADHD, you know, you're not going to see the levels of mania or impulsivity in ADHD that you would see in bipolar. But you could have comorbid disorders, by the way. You could have both ADHD and bipolar 1. So yeah, that can also happen. There's a dual diagnosis.
Thank you. Some questions are asked about childhood traumas, you know, physical abuse, bullying, and if they're not dealt with, is that is that linked to maybe having bipolar?
So when I was talking about causes, if you recall, I was saying that childhood trauma is sometimes implicated in bipolar mood disorder, or it's been found, research has found that people who have bipolar mood disorder often have childhood traumas, but it doesn't necessarily mean that if you had a childhood trauma that you'll end up with bipolar. Remember, there's other factors. You have to have a genetic link as well. You must have another severe, trauma that's happened to you right now. There must be some family history of depression, so that all of those factors together may place you at risk. But no, it doesn't mean that if you've had trauma you necessarily get bipolar. No, I don't want to scare you off. But research has shown that people with bipolar often have trauma. I hope that makes it clear.
Yes. I think there's a lot of questions, or there are some questions that are out of the scope of this presentation, for instance, like differences between borderline and bipolar and schizophrenia, overthinking. And I think it's definitely a topic that we can include going forward in our mental health discussions, as it's important we continue with this. Someone asked, is there a link between bipolar and PTSD? So asking about some other diagnosis, but I am aware of the time as well. So I think I'm aware of the time as well, and our next speakers, in fact. I don't know, Kath, if you're able to see any other pertinent questions in the chat. It's difficult to get to all.
There's nothing so far. I think she's answered most of the questions that were there.
Okay.
Yeah. Okay, we're gonna move on now to our next speaker, Ms. Rolene Steto, who's our student mentor. She's also a student in BA Forensic Sciences and Technology, and she's just gonna share a bit with us about her mental health journey. Rolene?
Hi, Kathy. Thank you so much, guys. Thank you. Good day, everyone. Clearly, the introduction has already been said. But my story actually started in 2016, where everything in my world changed. I had only been in culinary school for only 1 week, and I woke up to the devastating news that my brother was killed. There is no cushion for such a blow. I literally thought I was dying. I couldn't even cry at my brother's funeral. I was so numb. But I got so much praise from people around me, community members, saying how calm, cool, and collected I was, because I was actually basically the strong Black girl or woman in that sense during that time. And everyone believed that that's what was needed for my parents or my family. And I thought I was doing it right. I was healing and not focusing on the negative aspects. I thought if I just kept pushing and pushing and pushing, I'll be okay or I will get through everything. But that's not how it was. I was losing a piece of myself and I had no idea. For the entire year, I basically survived. I pushed through, worked every chance I got. I didn't have a life. I was toxic. I was in fights. I was the common denominator for every bad thing that happened around me. I just couldn't get it right. And then 2017 came, and in the same month, my brother had passed away. In the year before, my cousin goes missing. She literally just runs away from home. I lost it. I couldn't hide it. I couldn't pretend anymore. And I was a broken human being. I was just really broken. I became a little tiny girl all over again. But that's not what the elders or the people around me saw. They saw a lazy girl. They saw incompetent. They saw a crybaby. My parents thought I was rebelling against them. Family thought maybe I was on drugs. Some thought that maybe I was being abused by my partner. It was hell. It was hell on earth. Sorry for my coping mechanism of laughing. It was really the worst time of my life. And then I just kept pushing though throughout the whole 2018, 2017. I was in and out of hospitals, mental institutions. I was sick physically, mentally, spiritually. I was sick. I was vomiting every day, I had headaches, I was fainting. Wherever I went, I think you could see that I was depressed, but I guess it came out in a wrong way because I was so angry. I was angry at myself the most, blamed myself for my cousin's disappearance, blamed myself for my brother's death, which was so irrational, but I still did it. And one day when I was in one mental institution, it changed my life because I really did not think that mental institutions were this fun or rather relaxing. They pampered me. They showed me how to take care of myself. They let me pause for a second and look inwards. And the only bad experience I had in mental institution was being in a group and hearing the stories of other people. There was a lady who changed my perspective forever. She had said to me, 20 years ago, I lost myself and I've been in and out of the same institution for 20 years. I still don't know where that girl I had lost is. I felt like that was me. I thought, oh my goodness, this could be my future. And I knew it could never be me. It could never be me. I started working on myself religiously. I remember 2018, my very first resolution was to never go into a mental hospital ever again, which was a weird thing, irrational, of course. But I felt like if I could take care of myself, I'll be okay. And the worst part about it is I pushed everyone away. Everyone that wanted to love me, care for me, I pushed them away and made this healing just about me. And probably it was one of the most selfish things I did, but at that time, it was the only thing I could do, was to make sure that I was going to heal on my own. So I closed myself off from everyone around me and started my healing journey. I fell in love with holistic healing. I started meditating. I started gratitude journals. I started learning law of attraction techniques. I started just building a bubble of safety for myself. And I was still in culinary school, still struggling to go to school, still struggling every day. I'd wake up in the morning, get to class and cry, bawl my eyes out. Nobody knew what was wrong, but I did that for 2 years in this culinary school. And one day I was in a hotel and I cried. I came in the morning, 6:30. I came there and I started bawling my eyes out. And the staff around me was so nice to me. They were encouraging, trying to keep me calm, trying to understand what was going on. And then a classmate came and she said, "You don't have to help her. She's a crybaby. She can never be helped. She's always crying." And everyone around me took it as a joke and they laughed. But in my head, that was when I said, I can't do this anymore. I'm not going to take this anymore. And it was that moment I decided it's either me or the school. My mental health is more important. So I told my friends, I'm dropping out. I need to quit. And one of my friends said, "Listen, if you quit now, you're going to quit for the rest of your life. You once a quitter, always a quitter." I didn't care. I quit anyways. I left home and I stayed on my own and started doing things to make sure I knew myself. I did shadow work. I literally just sat with myself for a whole year doing absolutely nothing but figuring myself out, figuring out my triggers, figuring out ways I can deal with my triggers, how to even know which symptom could bring that trigger, or what do I have to do to be a better person for myself. And then 2019, I was pregnant and the urgency of me bettering myself grew, because now I needed to be a healthy version for my child. I was not going to bring my child into this mess of who I am. I had to get better and better. So I doubled down on all my healing and I felt like I was creating a new person. I don't think I would ever tell you how different the Rolene is now from the Rolene in the past. She's completely a different person and I kind of like this one better, this new one. So as I started figuring myself out, I told my mom, "Mama, I'm going back to school. I want to try again." And my mom, with education, she was like, "Let's go, let's do this." And I tried, and I actually applied for forensics. I really didn't think I would like forensics. I just wanted to understand my brother's passing. Why did this happen to him? What pushes someone to get to a place like that? What makes a person wake up in the morning and think, this person does not deserve to live? And that was my why for being in forensics. And I fell in love. I fell in love with every single aspect of forensics. My passion grew for helping people. My passion grew for the victims that are going through, and the people that lose their lives. They needed a voice, and I felt like I wanted to be that voice. And I studied with my son on my lap. I wrote exams with my son on my back, walking around. I remember the hell I went through. I was still going through depressive episodes, but I was handling them a bit better. And this whole time I was doing this without any medical help, not because I didn't want to, but mostly because it was expensive. First of all, I didn't know that there were government assistance that you could actually get. And also, I was really good at masking my pain. I was really good at hiding it, that the doctors, psychiatrists, they thought there was nothing wrong with me. They thought I was okay. And then I just kept going. I kept going, and I got better and better at realizing when I'm about to go into an episode, how do I get myself out of it? I usually say depression doesn't define me. Depression is the little girl that comes to me. She's sad, she's angry, and she just needs me to love her back to normal, back to who she was before all the pain. And that's how I kept going. And I remember the second semester of the second year at Unisa doing my forensic, I failed all second assignments for every single module. There's a module that is got to do with methodology. I got 17% for that assignment. I cried my eyes out. I was like, this cannot be happening to me again. In the second year, again, I'm about to drop out. I'm about to quit. And I remember my mom telling me, girl, we're not doing that again. We're going to finish. You're close to finishing. And I wrote my exam. I wrote some of them with tears in my eyes because I could not study. I was so depressed and I was so terrified. And I didn't know that there were tools and places where I could go and talk and actually get help. And I'm so sorry, guys, I'm talking too much. And now in 2023, I found the mentorship program, and they picked me and some of us, my team, and they've changed my life, even though I don't think they know. They've changed my life a lot because they gave me the safe space to talk. They showed me that I can heal others by healing myself. We did a lot of self-development. I learned so many things about myself during this program, and it also gave me the platform of what I wanted to do for so long, which was to give a voice to people that are hurting. And I'm so grateful for them. I'm always vulnerable around them because they are literally a safe place for me. And even though I went through all of that for so many years, I'm so proud to tell you guys that I'm graduating next week. This is not a surprise, even though it is kind of, but I'm so happy that I got here. And it just shows that if you keep pushing, believing in yourself, you push yourself, you put yourself first, you can go anywhere. You guys are needed. You guys are loved. You guys are important. And even though I did try to commit suicide about 3 times, I did try to do everything possible to make myself unworthy of this opportunity, but here I am today, and I know that you can do it. And there's one exercise that I would like for everyone to do with me that has helped me understand or given me a great perspective. The exercise is to put 2 fingers on your pulse, whether it's your neck or your wrist. To put 2 fingers on your pulse. I'm sure you can feel it's beating. Now put your hand on your mouth and breathe onto it. You still have warm breath in you. That means you are alive. You are still here. Means you are still needed. And without you, we can't do anything. The life we live, it's meaningless without you. And I hope everyone gets to know that. And I hope to tell everyone that you guys are not alone. I'm here. If you need anyone to talk to, I'm here. Everyone's here. There are so many resources that Unisa has opened for us, and this mental health awareness campaign is one of them that really just opens doors for you guys. And I'm thankful for you guys to give me this platform to actually tell my story. Thank you so much, guys.
Thank you so much, Rolene. Thank you for sharing such a beautiful and inspirational story with us and just allowing yourself to be vulnerable, to share your story with us today. I hope it inspires someone here. Thank you so much. I would like to call on Ms. Zamokutle Dlamini, who's also our student mentor, to introduce our second speaker for today. Zamo?
Thank you, Catherine. Good afternoon, everyone. As Catherine has mentioned, my name is Zamoguhle Dlamini. I'm a student mentor based in Pietermaritzburg. Today, I'll be introducing our speaker. The speaker will be speaking about suicide awareness and prevention. Ms. Bianca Freisler is an HPCSA registered counselor and is currently completing her internship in clinical psychology. Ms. Freisler completed her master's in psychology research in 2018. More recently, she completed her clinical psychology internship at Elizabeth Donkin Psychiatric Hospital. She was previously employed as a registered counselor at Nelson Mandela University, Mthonjeni Student Wellness for 12 years. Currently, she works as a lecturer at Varsity College and at a private practice in Gqeberha. Bianca's passion within psychology is about stigmatizing mental illness, thereby openly discussing the illness, causes, and treatment, while taking into the role of culture and spirituality into spirituality. She adopts a holistic and systems approach to maximize the individual's human potential. Within the therapeutic space, she offers clients a professional, ethical services, which allows her to create a safe space for the individual to explore insights into themselves and thus to promote growth, healing, and development. In the classroom settings, Bianca's adopt an inquiry-based learning approach, starting with a question to prompt discussion, then link it to the content. Please welcome Ms. Bianca Freisler.
Good afternoon, Donald. Thank you very much for that welcome and for that presentation. I sincerely appreciate it. Good afternoon to everyone in attendance today. I am very glad to be able to engage with you on the topic of suicide awareness and prevention. Talking about awareness and prevention, and I am aware that this is a very sensitive topic. And so it is my hope and my intention to deal as sensitively as I possibly can. But just very briefly, this is the overview of what I'll be sharing this afternoon. And what I was saying here is that when you look at the word suicide, it's actually derived from the Latin word called self-murder. And when we hear of somebody that has been murdered by another person, we are left feeling shocked and horrified and traumatized. Because we're like, how can one person do this to another human being? But if we think of it in the sense of suicide, we can ask ourselves the question, how is it that somebody is able to do this to himself? And we ask that question, I hope, in a very compassionate tone and not necessarily in a judgmental tone. Because if we really put ourselves in someone's shoes, or maybe you yourself have experienced suicide ideation or had a suicide attempt, we know that in that moment leading up to the thoughts or the actual attempt, how hopeless that person must have felt. And I think this just sheds the light on the concern when it comes to suicide. I'm not going to go into much of the stats, but just to say that October, as we know, is Mental Health Awareness Month. And the 10th of September has actually been dedicated worldwide to World Suicide Prevention Day. because there are such high rates of suicide on a daily basis, almost 3,000 people a day. And I wanted us to also look specifically at South Africa. And if we look at this table, it has suicide rates by country. Here we can see South Africa fall number 9, which to me is concerning. It's alarming that so many South Africans have attempted suicide. And then we also know so many South Africans are actually experiencing suicidal thoughts and also have attempted suicide before. And so this just highlights that this is a much needed topic. And if you missed what I said at the beginning, let me reiterate it. Suicide is a very sensitive topic. And so I am trying my best to tread very lightly and sensitively, but I also know it is a much needed topic. So I am so honored to be part of this mental health program where we can actually talk about suicide openly and also get the correct information out there. Just looking a bit more at South Africa, in 2015, a research study was done on youth suicidal behavior, and they found that 4 to 15% of that sample experienced suicidal ideation. Now, suicidal ideation, what that means is you're having thoughts about attempting suicide. So thoughts like, I want to end my life. I don't want to live anymore. I want this to be over. And also starting to think of a plan on how you can actually attempt suicide. From the sample, 2 to 12% were actually planning an attempt, and 1 to 6% actually had a previous suicide attempt. Again, this is alarming, and it highlights to us what are South African youth experiencing. Amongst this age population, I think many of our students are, age 18 to 29, and I know we also have mature students. But suicide is the 4th leading death cause of this age category. Again, reiterating how concerning this is. Whenever I think about South Africa and I think about suicide, I'm always taken back to this famous artist, Ricky Rick, who committed suicide in 2020. And I think what was alarming to me is seemingly when we look at Ricky Rick, we see, he had it all. He had a booming career. He was well known in South Africa. He had a family, wife, children. He had, financial wealth. But very few knew that he was actually struggling with depression and struggling for years. He also battled with addiction to drugs and alcohol, was in and out of a rehab facility as well. And this is one of the quotes he left as when he was battling his mental health. He said, "I'll catch you on the other side. And if you never hear from me again, I love you and God bless you." And to me, that, I wonder really what was going through his mind in his final hours of his life. Like I said, somebody having what we would think is a good life is also battling mental health difficulty, and sadly then took his own life through suicide. And this also can help us understand what are the signs and symptoms when it comes to suicide. Okay, so a link between suicide and mental disorders has been observed, particularly depression and alcohol use disorders. Depression is the #1 mental health reason for suicide, with more than 80% of depression disease burden occurring in low to medium income countries, which is a country like South Africa. We also see that anxiety disorders and psychosis and schizophrenia is linked to suicide. Now, I know we've just had a session on bipolar as well, and there Dr. Hendricks also confirmed to us that bipolar is another mental disorder that is linked to suicide. So what does this tell us? That when somebody has a diagnosis such as depression, alcohol use disorder, even any substance use disorder, anxiety, psychosis, schizophrenia, bipolar, this is often a precipitant. In other words, it's a factor that can contribute to a person experiencing suicide ideation or attempt. Now, we also know that a lot of people are not able to access mental health professionals, so they don't even have a diagnosis. And so we also know that people who have symptoms are also at risk for experiencing suicide ideation or attempt. And so this now tells us that when we know somebody has a mental disorder, they are at risk. And particularly the diagnosis of depression, they are at risk for experiencing suicide ideation or attempt. I'm going to share some more signs and symptoms with you about what contributes to suicide ideation and attempt. And as I say, trying to tread very lightly when it comes to this topic. A major factor that contributes when we look at current stresses is when somebody is experiencing a stressful event or consistent low level of toxic stress. And if we think about some of the stresses that students particularly face, okay, it's financial issues, it's the lack of funding, either from NSFAS or from scholarship or even from family. It's having modules that are very difficult, repeating the module, failing the year. Because for students, you're in the stage of trying to find your romantic partner, relationship difficulties are a major stressor for students. Students are in relationships, but sometimes there's cheating or there's domestic violence. There's also the difficulty of how to maintain a healthy relationship. And I know this is a major stressor for students. And also ongoing family conflict is a major stressor for students, and also unemployment. And I think for many of the Unisa students, they are studying part-time, and it means that they have maybe the time to work, but there's not often employment available. Or even if you graduated, maybe you're a postgrad student that's in this audience today, and you know you've got your degree, and you actually couldn't find a job with that degree. So one of the major contributing factors to suicide is experiencing a stressful event. What we also see, secondly, a major concern is lack of social support. When an individual feels like I'm alone, I don't have anyone that I can connect with, I don't have anyone that I can actually reach out to in my time of difficulty. As Dr. Hendricks also pointed out earlier on with mood swings, this is another factor linked to suicide, is when one's mood is unstable, you go from periods of excitement to depression, and that can also contribute to experiencing suicide ideation. As we know, sadness, and here we can also think again of depression, just a constant state of sadness contributes to suicidality. Dysregulated sleep, so maybe having insomnia, because if we are not sleeping adequately, if we're not getting quality sleep, that affects the neurochemicals within our brain. And so we will have mood swings, we will have sadness. And we often overlook the value of sleep. I know also as students, especially now exams are coming up, you're pushing. But again, this can have alarming effects if sleep is not regulated. What also contributes to suicide is a sense of losing control. So feeling like you're not in control of your life or your circumstances. And then a major symptom we look out for when it comes to suicide is hopelessness. Because sometimes you can be going through a difficult situation. You maybe feel like you're alone, you're sad, not sleeping, but there's an element of hope that, you know, this is going to get better. At the moment we see somebody's experiencing hopelessness, that is one of the symptoms we take extra caution when somebody tells us they are experiencing suicidal thoughts, because when hope is no longer there is nothing to carry one to the next moment or to the next day. What we also see with current stresses is when somebody's emotional reaction is either that of being aggressive or aggressive impulsive. So when there is a stressor or something happens that doesn't go according to your plan, the person responds aggressively and also impulsively. And impulsivity is a huge concern when it comes to somebody having suicide ideation. Because 1 minute they might be fine, so, you know, okay, I have this thought, but I'm not going to act on it. But because of that impulsivity, moments later they could change their mind and just decide, you know, I'm going to do this. Bullying is also a factor when it comes to suicide ideation and being a victim or a perpetrator. And what we also see as a factor is having access to lethal means of suicide, including medication, firearm, ropes, razors. That is also a factor that contributes to suicide ideation or attempt. So what I've done now is I've looked at current stresses. Maybe this is something that the person is experiencing in this moment. But we also know what contributes to suicide is childhood trauma, such as physical, sexual, and emotional abuse. Or if somebody has been abandoned or rejected by their family member, or there is death of a loved one. Now, again, this could also link to mental health disorders such as depression, complex PTSD, personality disorders, or bipolar. But we do know that people that have had these past stresses have often reported feelings of or thoughts of suicide. And then at the bottom, I put this, the little block that says previous suicide. So what we also see is that when somebody has attempted suicide once, there is a likelihood that they might attempt suicide again in the future. And so that again is another concern when somebody discloses to us that they have indeed experienced or experiencing suicide thoughts. I've touched on this already, but again, just, you know, when we talk about the stresses that students face, it's financial difficulties, it's failure, it's relationship, it's family, stresses, it's unemployment. And so all of this could contribute to a student experiencing suicide ideation or to actually attempting suicide. Something that is also very interesting when it comes to suicide is the difference between gender, males and females. What we see is that males were consistently found to attempt suicide less than females, but males died by suicide at higher rates than females. And why is it? Why are men's suicide attempts more successful than females? Often it's because men are very difficult to reach and their help-seeking behavior is less than females. Men's presentation of suicide is also very different. They present with more aggression, antisocial behavior, risk-taking behavior, irritability, and increased addictive behavior. We also see with men that they often in a more positive mood in the days before they actually attempt suicide, and often the family would feel oh, but this person is actually doing better. And what we see with females will report more depressive symptoms, interpersonal conflict, sexual assault. And what we also see with females is that females will actually reach out to a mental health care practitioner when they are experiencing suicide ideation, where we find with men they actually don't. And so what that also tells us that is whether you male or female, if you reach out to a mental health care practitioner when you have a suicide thought or a plan, that you can get the necessary help where you actually don't attempt suicide. So yes, the presentation of gender is very different when it comes to suicide. And I know even as a psychologist and mental health care practitioner, we always take that into account. Just very quickly on suicide-related communication, on having worked with patients who have attempted suicide before, or also working with patients who a loved one has completed a suicide. We always ask that question, did the person leave a note? 60 to 80% of all suicides are announced beforehand, whether it's directly or indirectly. But what we also see is that men are more likely to inform their partner, where, as I said earlier, women will actually contact a healthcare provider. And I think this becomes very difficult when somebody has successfully completed a suicide and there's no note, because now people are left with so many questions. Something I also wanted to point out is the element of self-harm, which is actually more common than suicide. So self-harm it's a behavior that people often engage in to manage difficult emotions such as cutting, burning oneself. Let's say you're only supposed to take 2 tablets, you end up taking 4, so you're not intending to overdose, but you are harming yourself in the process. And what we do know is that if somebody repeatedly engages in self-harm behavior, this makes them at more risk for suicide. And again, this is also something that we need to be aware of when somebody has a mental health disorder. Are they engaging in any self-harm behavior? Now, looking at the treatment of suicide, okay, there are 4 options. I'm going to talk quickly about the assessment, home-based care, hospital care, and more importantly, how we need to treat the mental health condition. So when a client presents at a psychologist or chief psychiatrist, and they either directly inform the practitioner that they're experiencing suicide thoughts, or the practitioner is able to determine that this person is possibly thinking about suicide, I want you to know we will always directly ask, and that is me in therapy as well. If I suspect somebody has suicide ideation, I'm going to ask about it, because this is the one place that you should be able to talk freely about it. And so when we become aware that somebody has suicide ideation, we explore all these factors. We look at what are the thoughts, what's the intent? Is it to self-harm, or is it to actually complete the suicide? We look at what is the method. We look at the precipitating factors, going back to what is the stress the person is currently experiencing, or past stresses. And we also look at family factors. Why we look at family factors? Because that is the one way we can begin to identify support. If we deem that somebody is a suicide risk, the first goal is to do home-based care. This is where the psychologist or psychiatrist, mental health practitioner will engage in a no suicide contract. This is where we make a oral or written agreement that the patient will not attempt suicide before the next appointment, and we put different measures in place. We give them access to 24-hour call services. We talk about, okay, what behavior can you engage in? Instead of harming yourself, there's something else you can maybe do. We also if you look at the second point, we monitor contract. So this is where we bring in family or friends that can support you, that can actually watch you over the next week so that you don't harm yourself. We develop a treatment plan and we do active follow-up. Now, a lot of people will say, oh, this is just an agreement between you and your psychologist. It means nothing. I can tell you that this agreement has saved many of my patients' lives and so many of my other colleagues, their patients' lives, when we have this agreement in place. Because what we're doing here is we're acknowledging that yes, you are experiencing suicide ideation, but we are putting plans in place. We are taking it serious, but we know right now that you are feeling hopeless and that this might pass because the crisis might resolve itself, or we can figure out how to solve this problem that you're having, or we can get you the correct treatment for the mental health disorder that you are facing. And so this method has proven time and time again to be effective. Obviously, there were times when this was not effective, and for that, one is always left with feeling sad and what could I have done differently. If we find that home-based care is not sufficient, then we look at hospital-based care. And here we have voluntary or involuntary. Voluntary means you will say to the patient, I think it's best that we place you in a hospital where you can be taken care of, you can be placed under observation, you'll be fed, you'll be clothed, and you'll be cared for by various healthcare practitioners. And so the patient will agree, yes, I would like that. But we also know that sometimes patients don't want that. They're adamant that they want to go ahead with a suicide or that they'll be fine. But we do know that according to the Mental Health Care Act 17 of 2002, we can actually have patients involuntarily admitted. If you are ever placed in a hospital, as I said, you will receive intervention from a multidisciplinary team, a GP, psychiatrist, nurse, psychologist, and so forth. I'm just keeping my eye on the time, so I feel I'm getting close to the end. So that's speaking more from a psychological perspective or from the perspective of a healthcare practitioner. How can you, that's in the audience, support somebody that is experiencing suicide ideation? Now, in no way am I saying you need to be a psychologist, not at all. But we can listen to that person. We can ask them questions gently and non-judgmentally. Tell me about your thoughts. How long have you been feeling this way? Offer hope and encouragement. I didn't say advice, okay? Hope and encouragement. Help them think through their problems and see possible solutions. Again, I said, help them think. Don't give advice, oh, you should do this. Because at this point, the person doesn't need to just be told, but they need hope, encouragement, support. Sometimes you need to remove items that they could possibly use. And then, of course, you need to ask them if they would rather speak to someone else, a GP, a psychologist, psychiatrist, or a helpline. If you are experiencing any suicide ideation, do not isolate yourself because this is a time when you need to reach out to others. And this is the time when you can reach out to a trusted family or friends. I know we sometimes have family and friends and we're like, but I can't just speak to them. They don't understand. That's what's a trusted family member. Consult with a psychologist, a GP, psychiatrist, so that they can actually help you. As I said to you earlier on, why women suicide rates are less is because they actually reach out for help. to a mental health care practitioner and then they get the necessary support and then they don't attempt suicide. So that there with reaching out for help is important. It's life-saving. There's also calling a 24-hour helpline. And in that moment, sometimes this is not always accessible, but journaling your thoughts and your feelings, engaging in stress management activities. What are your healthy hobbies? What are your coping strategies? Understanding how your thoughts affect your behaviors and your feelings. Also applying problem-solving skills. What is the problem? What are the solutions? Who can I ask for assistance? And I love this quote. It says, remember that you have survived 100% of your worst days. And you can survive that. Because often suicide ideation is based on something that is temporary or something that the person believes cannot be fixed. So very important, if you are experiencing suicide ideation, do not isolate yourself. I think for the sake of time, I'm going to skip those 2 slides. And then one of the resources that are extremely useful is the South African Depression and Anxiety Group. I took a screenshot. There's all the phone numbers. And even if you look on the left, they have even more numbers you can contact. And I know that from the Unisa team, they will also share their contact details where our students can go about reaching out to them if they are experiencing suicide thoughts, or they have a plan, or even just having any mental health condition. The Unisa counselling team is there for support and intervention. And that brings me to the end of my session. Thank you very much for this opportunity. I'm not sure if there are any questions. But yeah, that's it from me.
Thank you so much. Candice, do we have any questions?
Thank you, Madam Program Director. I noted that Dr. Hendricks has been responding to some of the questions in the chat. I don't see any questions about suicide and suicide prevention at this stage. I don't see any questions. If there are any, we can take a hand from the floor, but I am aware of the time and our presenter needed to also get to another commitment shortly. There was one hand, if we can maybe take a question from one hand. Bianca, would that be fine? I see there's a hand from Nokupiwa. Can we take one question? Just one question. Is someone who has experienced bullying during their schooling years likely to go through depression and suicidal ideation or suicidal, suicide? Is that one question?
Okay. Thank you very much for that question. And yes, if somebody has experienced bullying in high school, they are at risk for developing a mental health disorder and could then also be experiencing suicide ideation. Note I said the word they are at risk. So it doesn't mean that if you have experienced bullying that automatically you will have symptoms of depression or have suicide ideation. But we do know that bullying does cause psychological harm and therefore can place one at risk for developing a mental health disorder or suicide ideation.
Thank you so much. I just want to thank our speakers and our students for attending today session, and thank you for being such a wonderful audience. I'm just gonna hand back to Candace to just give a vote of thanks. Thank you.
Thank you. On behalf of Unisa Counselling and Career Development Unit in the KZN region, I'd really like to express a heartfelt thank you and warm thank you and a sense of appreciation and gratitude to our speakers today, Dr. Shariefa Hendricks, Ms. Rowling Stato, and Ms. Bianca Smith. These were really complex topics to talk about and sensitive topics to talk about, but they were much needed. Thank you for your valuable contribution and for the work you've done in this field already. We commend you. Thank you. A special thank you to our student mentors for their putting the events together along with the team. And to the organizers, a special mention to Dr. Hendricks, who has been pioneering our mental health campaign as well. I think further discussions about this is definitely necessary to reduce stigma, to provide more support to one another. And we hope that this can be ongoing discussions or at least annual events. We encourage you all to seek help or if you need to, and to reach out. And I think lastly, just thank you to all attendees today. We do acknowledge that we went over time. We thank you for staying in the presentation. In conclusion, just thank you to everyone, and we would appreciate if you could please evaluate the session.